Welcome everyone to this session. I want to thank Shockwave for putting this together. This is going to be an incredible update on intravascular lithotripsy. We have an incredible panel of global experts, and after 3 short presentations, we're going to take questions from the audience. We'll make it as lively as possible. I don't want to delay any further. We're going to get started, and I'm going to be the first speaker. So we'll start right off out of the gate. Again, thank you to Shockwave, and we'll start with my introductory lecture. Good morning. Welcome, everybody. This is the Shockwave Satellite Symposium. Obviously, good afternoon if you're joining us from Europe, and good evening if you're joining us from Asia. We have a spectacular program for everybody today. I'm lucky enough to be joined by close friends and colleagues, Andrew Holden, who's joining us from Auckland, New Zealand, and Lorenzo Petrone, who's joining us from London, England. Again, my name is Robert Lookstein. I'm an interventional radiologist in New York City. We're going to start the session with an overview of the Shockwave intravascular lithoplasty technology. We're then going to move on to the most recent data sets, specifically the Disrupt PAD3 trial, and then lastly, just show some clinical case examples. So without any further interruption, these are my disclosures. What Shockwave does is it addresses what I believe to be the last Achilles heel of endoluminal therapy for symptomatic peripheral arterial disease, and that's the presence of moderate, dense, severe calcification. And as all of us as endovascular operators have found with the introduction of certainly drug-based technology with balloons and stents, severe calcification significantly reduces the arterial compliance of the target vessel wall. And this results in either heterogeneous or poor balloon expansion, unpredictable dissections, and then acute or even subacute procedural failure. I think we've all seen acute recoil on the table or a recoil once the case is about to be finished. And we all wish we had some other tool in our toolbox. Many of us have become very, very comfortable with debulking strategies, specifically in the form of atherectomy. And in many circumstances, there are significant concerns about distal embolization, flow-limiting dissections, and even perforation. So while I use a lot of atherectomy, I don't think it's a technology that suits all clinical situations. And again, I think this lends itself to a new disruptive technology. And then lastly, as we look towards evidence to guide our decision-making process using technologies, unfortunately, these cases with the most severe technology have traditionally been excluded from the pivotal device trials. So that there's really just been lacking evidence to guide our clinical decision-making processes moving forward. So many of us are familiar with the concept of lithotripsy. This has been a technology available for the treatment of kidney stones for over 20 years now. And the idea is that you're applying ultrasonic waves from an external source to fracture and fragment kidney stones that are perceived to not be able to pass through a patient's genitourinary tract. But by fracturing and fragmenting it, fractures it into small pieces that lends itself to, again, be able to pass. And so the idea, which was created over a decade ago, was can we use the same technology in an endoluminal format to treat intravascular calcification? And thus was the introduction of the Shockwave balloon, where you have these lithotripsy sonic wave emitters on an angioplasty balloon that can be easily delivered into a vessel, use it to treat intravascular calcification and fragment the calcification within the vessel wall to lend itself to be more amenable to treatment with other technologies. So the idea is you take a standard angioplasty balloon, in this case, again, the Shockwave balloon, introduce it to the target vessel, inflate it to a relatively small atmospheric pressure. In our lab, we typically use 4 atmospheres. Activate the technology, and the balloon plugs into a very small generator that's about the size of a television cable box that sits at the foot of the table. And then a series of treatments, which is the submission of this ultrasonic energy into the vessel wall, happens for approximately 30 seconds. At this treatment point, the calcium is fractured, it's made much more compliant, and then the balloon can finally be inflated to its rated or even burst pressure to achieve uniform luminal gain within the vessel wall. This is an electron micrograph showing very, very dense, severe calcification in the vessel wall. And then after lithotripsy, lithoplasty, you see these fracture planes within the calcification. And you can imagine that an angioplasty balloon will be able to, again, expand the vessel wall more uniformly to achieve luminal gain. We've all had our experiences where we've placed a scaffold into a densely calcified vessel. The vessel just won't expand. And again, these fracture planes will allow for much more uniform vessel expansion at the time. This is a movie and a cartoon on the bench. In a phantom model, again, the lithoplasty generator is in the center of the screen on the left. This is a movie demonstrating what the energy does inside the vessel wall. You can see the shockwave emitting through the balloon to outside the vessel, and then the acoustic wave collapses almost instantly. This is repeated dozens of times during a treatment within the vessel wall. And again, you can see how this would affect the calcification that we're trying to augment during a lithoplasty therapy session. Again, another benchtop model. You can see once the shocks are emitted, this dense material that's surrounding the balloon fractures and fragments. It's very effective on hard material, whereas alternatively, if you just press on it with your fingers, you don't feel a thing. And so it does nothing to traumatize the soft tissue. This person who's literally gripping it with their fingers has no pain. There's no disruption to the tufts of their fingers, et cetera. So it's really a finely tuned therapy for non-compliant tissue within the vessel wall. These are just a couple of case examples from New York. You can see in the image on the left, really spiral dense calcification within the vessel wall that we're treating with long segment lithoplasty. Here, we had prepped the vessel with a small balloon, and the vessel collapsed on itself instantly. We felt we were going to need to put in a scaffold. And this is the lithoplasty balloon being advanced throughout the course of the femoral artery. The middle construct is dense eccentric calcification, where you can see the balloon is just being adjusted to really, fracture that calcification there. In my humble experience, this severe eccentric calcification doesn't lend itself that well to debulking therapy. And so lithotripsy, lithoplasty, it just works very, very well. And after this therapy, we actually got excellent luminal gain with the placement of a scaffold there. And then in the video on the right, we've all faced this in patients with a chronic limb-threatening ischemia, where you have dense circumferential calcification in the infrapopliteal vessels. And in this patient, after balloon angioplasty, we had acute recoil on the table. This patient had tissue loss. And we were able to introduce a low-profile lithoplasty balloon into the dorsalis pedis artery. And after a brief therapy with lithotripsy, we're able to maintain luminal gain and restore perfusion to the affected limb. So again, just some examples from our lab in New York of how we've used this technology over the last year or so. Where are we going in the future? Obviously, there's extensive experience now using this technology in eccentric and concentric calcification within a number of different vascular territories. There are some operators that are using it as standalone therapy. I prefer it to use it as an adjunct prior to either drug delivery therapy or the introduction of a scaffold. It truly is a new form of vessel preparation when other therapies fail. Obviously, endoluminal therapy is an alternative to surgery. I think the most common vascular territories that are currently being used are obviously the femoropopliteal segment, and I just showed you an example of the infrapopliteal segment. We're all familiar with the growing experience of it being used in the aortoiliac segment as an adjunct to EVAR, TVAR, and even TAVR. I personally think it's an excellent technology for use in the common femoral artery to avoid implanting a scaffold or even performing an endarterectomy. And then, as we're all aware, it recently received FDA approval for use in the coronary circulation. So there's a number of different modifications to the balloon, the M balloon, the S balloon, and the C balloon that are being commercially available and distributed across the country and around the world. So it really is a very, very optimistic time to be thinking about this technology and obviously using it in a more liberal manner. Without any further interruption, I'm going to introduce my dear friend and colleague, Andrew Holden. Andrew is going to share with us the results of the Disrupt PAD3 trial. Thank you, Andrew.
Hi, I'm Andrew Holden from Auckland, New Zealand, and it's a pleasure to bring to you some new information from the Shockwave Disrupt PAD3 trial, both the randomized control trial and the observational registry, and these are my relevant disclosures. Well, Shockwave have been involved in an extensive clinical program evaluating intravascular lithotripsy in lower limb arteries, starting with the Disrupt PAD 1 and 2 trials, which were performed in New Zealand and in several European centres, really showing excellent safety and also some very early efficacy signals which were positive. There was then a small below-knee safety and feasibility trial using Shockwave in tibial arteries that also showed safety and some efficacy signs. But what we're really going to focus on is the Disrupt PAD3 randomized controlled trial. Really the largest randomized controlled trial evaluating moderately to severely calcified lesions in femoropopliteal arteries to have been performed. As you can see, 345 sites in the US, Europe, and in New Zealand. Just looking at the design of the trial, all patients needed to have moderate to severe calcification and femoropopliteal lesions. As mentioned, 306 patients, randomized for vessel preparation to conventional angioplasty, PTA, or intravascular lithotripsy in equal numbers. The patients then received an anti-restenotic therapy in terms of the Medtronic Impact drug-coated balloon, as well as a stent if required, and they had follow-up initially at 30 days and then longer follow-up. So we're really focusing on procedural success, that is the successful vessel dilatation with either conventional angioplasty or intravascular lithotripsy, and procedural success defined as a less than 30% residual stenosis without a significant flow-limiting dissection that is greater than or equal to grade D dissection. Now, there are also some secondary endpoints at 30 days, clinical endpoints, walking impairment questionnaire and Rutherford categorization and so on. And we're going to wait for the 12-month powered secondary endpoint of primary patency. So if we have a look at this study, it really represented real-world hostile lesions, 306 lesions randomized to intravascular lithotripsy or angioplasty. 83% of them had severe calcification by Park classification, and the calcified lesion length was 129 millimeters. So certainly real-world lesions. We have a look at procedural success. Not surprisingly, as we often see, there was a difference in outcomes whether they were site-reported or independent angiographically core lab reported, but nonetheless, there was a highly significant treatment effect, whether you use site or core reported outcomes with a significantly better procedural success with intravascular lithotripsy, a lower rate of residual stenosis, less than 30% diameter loss, or significant dissection. So a highly impressive improved procedural success with intravascular lithotripsy. If we have a look at some of the other procedural characteristics, we see that there was a 44% reduction in the pressure required to achieve dilatation success. Very impressively, a 75% reduction in provisional stent placement with intravascular lithotripsy, a 69% reduction in the need for post-dilatation after IVL, and finally, as we've seen in the other DISRUPT trials, a very dramatic low incidence of dissection requiring intervention after IVL, a 77% reduction in grade C or worse dissection after IVL. We can see if we compare the DISRUPT 3 randomized controlled trial to the first 200 patients seen in the wider observational registry where IVL was used in a number of lower limb arterial locations, that actually a very similar pattern. The pre-treatment lesion severity was similar, but then we saw this very impressive improvement in stenosis severity reduced to below an exploratory endpoint of 30%. For the randomized controlled trial, 27.3%, further improved, a final result of 21.5%. Very similar outcome with the observational registry. So I discussed the observational registry, and we'll talk about that in the next few slides. This is a single-arm observational registry, up to 1,500 patients recruited in the US, Europe, and New Zealand. These are patients with lesions in all lower limb arterial locations from iliac to tibial arteries, treated with intravascular lithotripsy, and then clinicians of subsequent treatment of choice. What we're going to focus on is an interim analysis of the use of the Shockwave S4 intravascular lithotripsy catheter for infrapopliteal calcified arteries between July 2018 and August 2020. 101 patients treated with this system, which is available in diameters of between 2.5 and 4 millimeters for tibial artery treatment. So if we have a look at this cohort, you can see that the vast majority of patients received intravascular lithotripsy only. A small group also received atherectomy or treatment with specialty balloons. 114 lesions were treated in these patients, 70% of these with critical limb ischemia, and 35% having chronic total occlusions. You can see in a small group of patients, drug-coated balloons or stents were placed, but the vast majority of patients, IVL was the standalone treatment. If we have a look at the outcomes in this Bologna group with the S4 catheter, we can see it compares very favorably to the overall randomized controlled trial or to the observational registry, where we have this significant improvement from baseline severity of 83% to post-IVL dramatic improvement below the exploratory endpoint of 30%, with an even further improvement after final treatment of 23%. The other thing you'll see is we've seen an excellent safety profile, so that not only in the randomized controlled trial did we see a complete absence of dissection or perforation. In the Bologna trial, we also see an absence of these complications, but also distal embolization, which is very pleasing. So the key takeaway points are that the DISRUPT 3 randomized controlled trial is the largest ever randomized clinical trial of severely calcified peripheral lesions, and it demonstrates that IVL shows superiority over angioplasty. We saw superior vessel preparation achieved at lower pressure with fewer stents, less need for post-dilatation, and fewer dissections. And we provided randomized data, which is consistent with the real-world outcomes we've seen in the observational registry. We've also seen an interim analysis from the real-world Disrupt PAD3 observational registry focusing on IVL with calcified infrapopliteal arteries, and we've reported safety, but also some excellent efficacy with minimal angiographic complications. And this data does add to the body of IVL evidence confirming the consistent safety and effectiveness of IVL across multiple vascular beds. Many thanks for your attention.
I want to thank Andrew for sharing with us the latest trial data from Disrupt PAD3. I'm now going to introduce Lorenzo Petrone, who's become one of the globe's leading operators with the use of this technology. He has an incredible experience, and I think he's going to show his incredible diverse experience using this technology for the most challenging applications. So in advance, thank you.
Hello, dear colleagues. It's Dr. Lorenzo Patrone from West London Vascular Interventional Center, and today I'm going to speak about IVL in real-world cases. These are my conflicts of interest, and this is what you have just seen. So in the observational study, IVL has demonstrated to achieve a low residual stenosis, high acute gain, and low rate of complication despite the complexity of disease. And these data have been also confirmed by the 6-month data of the randomized control trial where IVL was used. And today my contest is to try to squeeze as many cases as possible in my 8 minutes. And let's start from this case, a 47-year-old ulcer of the first toe. You can see how the scan is showing a tube of calcium going down in the right leg, and you can see also there are some like a blinking of the eye in this kind of scan. You can see how hard the calcium is and how stenotic some tracks look. And this is the angiogram. You can see very well there's a different kind of stenosis here, very calcific, extremely rock solid stenosis. You can see here at the level of SFA, mid SFA, distal SFA, and popliteal artery. And you can see that we tried to cross with a balloon the IVL directly, but we couldn't do because the stenosis was so tight that we had to use first a 3mm balloon to try to open this channel of calcium. You can see how well you can imagine the calcium at the level of the SFA with this kind of picture. And then after that, we were able to push the IVL balloon through this stenosis, and we open the balloon in all the different sides. You can see distal SFA and the popliteal. We use a 7mm one, so just to upsize the balloon, very low atmospheres to achieve a good luminal gain, a good contact with the walls of the artery. So you can see even in the popliteal artery, then we achieved a fantastic result with a 6mm balloon inflated at nominal atmospheres, and of course non-IVL. You can see how the flow now is brisk. There's no very much significant residual stenosis at all the level, and especially at the level of the popliteal, which is the segment where no one wants to put a stent. Essentially, it's not just about the primary treatment. You can see also the vessels very easily recoil after angioplasty. This paper demonstrated, like in the BTK segment, but also this applies to all the other vessels. The elastic recoil was observed in 97% of the patients with a mean luminal compromise of 30% almost. So this is the case, the CO2 angio for this lady who had rest pain and 73-year-old. And you can see now the first of all the first treatment was achieved with a 4mm balloon, and actually the 3mm balloon instead was used distally, and the result was quite good. Probably the balloon was undersized, but also you can see after when she came a few months later, the recurrence of the rest pain, the stenosis are exactly the same. So you can see that the stenosis at the level of the popliteal artery P1 and the level of the distal popliteal are exactly the same. So for this reason, we decided to use the IVL, of course. You can see now the 5mm balloon inflated at this level, touching with the walls, and after that we use, of course, the normal balloon angioplasty 5 inflated at good atmospheres, and also the 4mm down into the anterior tibial artery. The result was pretty good, was outstanding, I would say. So no more residual stenosis, no dissection flap. And I have to say that the situation at the level of the foot was completely preserved. So the flow through this single vessel runoff no, absolutely no trash, of course, as we are used with IVL, and this makes the huge difference with atherectomy devices where there's always a risk of embolization, and particularly in patients with single vessel runoff, in my experience, are not very welcome. The next case also I want to show you is about the BTK. Also in the BTK segment, the IVL has demonstrated to be a very good device. You can see here the stenosis of the TP trunk. It's very stenotic in a patient with the ulcer of the fifth toe. You can see from the angio here when I perform a 3mm angioplasty just to open a little bit more the lumen, you can see how much calcium there is there. This is a place where, you know, if you were not using this IVL that you can see here expanding step by step at the level of the stenosis, you would have probably put a stent. So essentially, without any stent, we use then a 4mm balloon. Again, you know, remember to oversize the IVL compared to the nominal diameter of the vessel, and the result was pretty good. And not only at the level of the TP trunk, of course, but I want you to compare the pre and post angiogram at the level of the foot. You can see that there's a completely different flow, and in particular, you can see that the flow at the level of the fifth toe where the ulcer is. Finally, you can see a blush, which we couldn't see before. So this stenosis was definitely significant, and we were very happy to have treated it very successfully with just IVL and no stent. The patient then successfully healed, and you know, everyone was happy, the clinician and the patient. And another good territory for the IVL is at the level of the groin. You can see this is the typical, of course, endarterectomy, the surgical procedure, but in a patient like this, where the profunda is patent, but there's a very severe stenosis, 3.5 meter a second, which means significant at the level of the common femoral artery. You can see the CT, but you can even more appreciate the angiogram. You can see this kind of spike of calcium. It's quite focal stenosis, not all calcified, like sometimes where it really requires surgery. And in this case, we use the 7mm shockwave to open this calcium, to prepare the vessel, to make the vessel more ready for the successful angioplasty, which followed later. You can see the 10mm balloon inflated at this level, and this is the final result. So very good luminal gain. You can see even more better when I compare the pre and the post. You can see how the pre does this kind of very calcific and significant stenosis. In the post, there's no stenosis left, and there's no dissection, so no need for stenting. Essentially, everyone wants to play the good guy without putting any stent, but you know, sometimes you really need to reinforce your intervention. This is the case of another common femoral artery, very calcific lesion. You can appreciate even better in this kind of homolateral, contralateral view, sorry, LAO. And you can see that the calcium was very much affecting the flow at the level of this artery, where no SFA again was patent, so just everything was going to the profunda. And the stenosis was crossed very easily with our 014 wire, and then after that we decided to inflate the 7mm again shockwave balloon. You can see very well how much calcium there is at the level of this bifurcation. We inflated it even into the profunda to open the all residual stenosis. And actually, if you see the two, the first and the last wave of treatment, you can see how the balloon completely changed the appearances. So the balloon is more inflated because it created more space. And despite this, you know, we tried to angioplasty with a 7mm balloon just to achieve a better luminal gain after preparing the vessel, but this exploded straight away, so it was very difficult. We changed 3 balloons, there was a lot of calcium, and after that the result was pretty good, but still we were a bit unsure that this would have been enough, and for this reason we decided to stent this common femoral artery. So the deployment of the stent, you can see here, despite the previous very calcific lesion, was very good, and you can see also that the supera stent was exactly the same length of the shaft, so which is a very good point. You can see now the common femoral artery completely open and very widely patent. And also, I want you to appreciate these 2 videos. You know that stent was of course scrutinized with the flexion of the hip, and you can see here, even with the contrast, the stent is not compressed by the inguinal ligament, but especially by the calcium. So very good result with the patient who completely healed. Definitive treatment versus vessel preparation. This is the fight that sometimes people take for the use of shockwave. I think that no one of these 2 treatments has to work against the other one. They are both very good. The important is to shock the rock and to open the calcium, then to prepare it or to achieve the best luminal gain. The important thing is to, of course, to take care of your patients, because essentially as Patch Adams said, you treat a disease and you win, you lose. But you treat a patient and I guarantee you, you will win, no matter what the outcome. And with that, I thank you for your attention.
Okay, thank you so much, Lorenzo. Great presentation, great whirlwind into your experience about this. Andrew, I want to bring you in too. We've been talking about this, sort of relatively new technology. I think almost everybody sort of heard about this, and maybe people have used it once or twice. But there's very few people that really feel that they understand exactly the right place, exactly the right patient to use it in. So Andrew, I'm gonna ask you this based on the results of the primary results of Disrupt PAD3. How do you take those results and look at your practice of when IVL should ideally be used? And then how do you incorporate it as compared to other technologies? Lorenzo mentioned atherectomy. There's a number of different technologies that are available. How do you fix it and make it work for your patient population?
Well, thanks, Rob. That's a great question. I mean, I think in terms of the femoropopliteal segment, we've got the most data and the most experience, and my approach is pretty clear. It's the real go-to treatment for concentric calcium, as you mentioned in your discussion, Rob. I think intuitively, where we see this linear, bilateral, extensive concentric calcium, our other debulking strategies don't work as well. They're also expensive and time-consuming with an embolic risk. And, from the very first day, 10 years ago or longer, that we used IVL in that situation, we were very impressed by the efficacy of this technology, and that remains the same. So it really is our go-to for patients with concentric calcium. I still have some question marks in my mind with focal polypoid calcified plaque that we see sometimes, particularly in the popliteal artery. But actually, the evidence to date has shown that as long as we've got good technique and we're prepared to treat multiple times to microfragment this eccentric plaque, that we can achieve great results. And Lorenzo showed a couple of cases where you would have predicted, based on the eccentric nature of the plaque, that you wouldn't get good luminal dilatation and you'd get recoil and need to put a stent in. And often we get away with it. And I know that there is going to be some subgroup analysis looking at the eccentric and concentric stenoses in the Disrupt 3 randomized trial, and we'll wait and see what that shows. But my impression is that actually, counterintuitively, this technology also does very well for these eccentric lesions. I also have very clear understanding, based on our experience, of the value of IVL in calcified iliac disease, particularly aortoiliac occlusive disease, and as you mentioned, vessel preparation prior to EVAR, TEVAR, or TAVR. And really, even though we're using balloons up to only 7 millimeters, we see this dramatic compliance change, which means we can post-dilate or stent to diameters much larger than that and not get recoil. I think the big question is the role below the knee. I'm still a little unclear. We've had some great experience with both intimal and medial calcification. Exactly where this plays a role compared to atherectomy and plain balloon angioplasty, I think we still need to get more data to really understand that, and I'd be very interested in both of your opinions on that one.
Thank you, Andrew. Lorenzo, let me pivot to you because you touched upon this in your talk, and I'm going to try and answer a couple of the audience's questions with this question I'm going to pose to you. You sort of alluded to this, and that when you're dealing with severe calcification and there's single vessel runoff, you've become a little skittish about debulking, and you feel that IVL is safer in your hands. I actually personally believe the same thing. I think if I'm going to think about debulking for single vessel runoff, I need to use an EPD. So my first question to you is, do you think that that's a really good strategy to share with the audience members, that if you're worried about the runoff or if you're worried about tissue loss, that IVL might be a safer strategy than a more aggressive debulking tool? And then secondly, do you ever use an EPD with IVL?
That's a very great questions. Thank you so much. And I saw also there were two different questions were quite similar in between the audience. So essentially, it's the whole point is like it has demonstrated also, as Andrew said very well, that the embolization risk is close to zero with Shockwave. Where we have seen with all the atherectomy devices, they all require by IFU the use of a filter. So essentially, I think that Shockwave is a great tool, especially if in these cases, like you mentioned before. So patient with single vessel runoff where you don't want to trash, but I mean, even if you have three vessel runoff, no one wants to trash one of them, even if it's the peroneal. So I think that especially for not extremely long lesions, when you're intraluminal, it's definitely my device of choice because it allows you to treat quite from your picture, the one you showed with the lumen, where the calcium doesn't disappear, the calcium breaks and essentially creates more space for the normal balloon angioplasty to create a lumen without dissection and without residual stenosis. And the data again from Andrew, which presented like the rate of stenting is far lower. So why don't you use it in these lesions? It's quicker than passing, for example, directional atherectomy 4 or 5 times. Putting a filter, passing the atherectomy, and then maybe passing it again. A lot of contrast here. You just inflate the balloon, and as I showed, the balloon inflates slowly. Every time you inflate the 30 seconds of the cycle, then the balloon expands more, and that gives you a very good opportunity to see the balloon working against the calcium.
Thank you. Lorenzo and Andrew, to you too. Could you talk about how you size your IVL balloon for the lesion? Lorenzo alluded to this, that he always goes 1 millimeter over, or at least he's very comfortable using that in the femoral popliteal segment. Andrew, are you adopting the same strategy, or are you a little bit more conservative? How are you using the IVL size to your advantage right now?
Yeah, thanks, Rob. Yeah, definitely. I mean, I just touch on a couple of things here. We recruited about half the patients, a third of the patients to the Disrupt series 1 and 2. So about 30 patients. And actually, because it was so early on, we used embolic filters in all our cases and did not get a single case where we had macroscopic debris. So based on that, we're very confident we've had no complications subsequent to that. On your second point, yeah, when we looked at the outcomes of that Disrupt 1 and 2 trial, we understood that the cases that didn't do as well was because the sizing was not aggressive enough. And we've learned that actually IVL for patients tolerate oversizing extremely well with a very low incidence of dissection, which Lorenzo mentioned. So we tend to oversize, I'd probably say 0.5 to 1 millimeter oversize compared to nominal with IVL. That tends to be our approach.
Lorenzo, anything to add on to that about sizing specifically?
I mean, I think that sizing is a problem, generally speaking. There's people who size the normal balloon to a lower diameter. There's people who size the IVL lower diameter. The people who size the stent at the lower diameter. I think that it's very important, especially for the balloon from IVL, that if you inflate it like at 2 to 4 atmospheres, you need to touch the walls of these vessels. There's no way that you're going to get a good result if the let's say the signal is in the middle of the vessel. So be brave, inflate it slowly. You don't need to inflate it to 20 atmospheres. So you won't break the vessel, but you need to touch the walls and even to push on them a little bit.
I've gotten very comfortable using this before I'm planning on putting in scaffold. So if I look at a lesion, I know that a DCB is not going to get the result. I basically will go straight to IVL prior to placement of the scaffold. Have you guys migrated towards that approach as well, or are you still using it sparingly if you know the vessel is going to need a scaffold?
For me, I love to use it when I don't want to stand. So when I take the standing almost as a downside of the technique when it doesn't work. But essentially, I know a lot of people, as I mentioned also in my presentation, who are using this as a vessel preparation. I think it's also a matter of cost. So we see that in Europe, at least, it's not reimbursed. So essentially, people are trying to be more conservative in the use of this technology to achieve the best results, avoiding then the cost of a stent. but I think it can be used in both, as I showed also in my cases, in both senses with great results.
Andrew, anything to add on to that?
Oh, no, just I think the vast majority of our cases, I'm surprised we don't need a bailout stent. But what I have shown, as Lorenzo showed, is it's a beautiful vessel preparation for superior. We know how important vessel preparation is. And honestly, if you've performed IVL, the superior is very easy to deploy to nominal.
Totally agree with you. That will be the final word of the session. I want to thank my faculty, Andrew and Lorenzo.